Great, thank you to Alex TLC for the invitation to speak. I was asked to talk mainly about what we're doing for monitoring children who have a diagnosis of ALD but who are asymptomatic, who haven't developed a lot of the problems. So we'll dwell on that as the main bit. I will just take the opportunity as a couple of sideline notes to make a couple of comments about screening and some other specific therapeutics as we go through, just to add in as well, because I think that may be helpful to follow on from some of what we've been talking about over the weekend, which has been, I think, really fascinating and helpful insights. This is probably a bit small to see, but this just is a kind of an attempt at drawing out sometimes some of that complex journey that we go through if we have a child who has a diagnosis. We start out in that pre-symptomatic phase, before anything's going on. You're kind of thinking, I'm fine, I have no idea there's a problem. Then you go on and develop some symptoms, and you think maybe something's going on, I don't know what the problem is, and that may then lead on to some tests, some investigations, and hopefully a diagnosis is reached. Now we know what the problem is, and then we move into a phase of monitoring, which is watching how the condition is going, looking out for new problems, things that Alice has been talking about, the different things that might emerge. And when those problems emerge, then we think about what are the treatment options. Are there those symptomatic treatments, things that we can do to help with the issues that the condition is causing, and also think about those specific treatments, the disease-modifying treatments that are trying to get to the root cause of the condition to change the trajectory. Now, this pathway, of course, is slightly different if we make a diagnosis before you've developed any symptoms, and we'll look at the different routes into diagnosis. But how do we monitor things in the medical world? And again, this reiterates some of what's been said already. There are those things that we're doing, those clinical assessments where you're seeing the professionals in the clinic, the doctors, the physios, the speech and language therapists, who are assessing what you're reporting is going on with you or with your child, and we evaluate those different problems. There may be the sort of physical examination. For some of the conditions, there may be a very specific scoring system that's useful to kind of remind us what are the specific areas, the different issues that might be coming through. And there may be some useful laboratory tests. We've heard about some of the biomarkers that are useful to help monitor where the condition is going and how it's progressing, and part of that may include brain scans. So just thinking again at a conceptual level, how do we get to a diagnosis? What are the routes into making a diagnosis? Often, and the pathway we looked at is that symptomatic route in, where symptoms, problems have emerged, you have tests, and that leads to a diagnosis. But also, for some conditions, some diagnoses, we have what we would term a pre-symptomatic diagnosis, where you've made the diagnosis without those problems having emerged first. And so the different scenarios where that might have come about could be from family cascade testing, by which we mean someone in the family has had a diagnosis, we know it's a genetic condition, and so that's led on to testing for other members of the family who might be at risk, and so that may be how a diagnosis has been made. For some conditions, newborn screening might be done, and I'll comment on that in a moment for ALD. And it could also be an incidental or accidental diagnosis where maybe you've had tests for something else and it's brought up a surprise result. So maybe you've had some genetic testing for one area which has accidentally or incidentally covered a gene that then has led to a diagnosis. So for ALD, specifically for adrenoleukodystrophy, the symptomatic presentation is either going to be, as we've heard, because you've developed adrenal insufficiency and you may have some symptoms, problems from that, either an adrenal Addisonian crisis or low blood glucose episode, something like that, or you've developed the neurological problems, things coming either from having the brain disease or the spinal cord disease from the condition. So you can have a symptomatic route to get the diagnosis, and then the same pre-symptomatic areas that we've talked about. Professor Kemp has told us about the newborn screening program in the Netherlands, and just to add on to some of the comments from that, where we are in the UK, it's still under review with the National Screening Committee, and there is an ongoing process, and we are working and feeding into that process, but it's not part of the current newborn screening. You may also have heard about the Generation study, which has been in the news recently, which is a new research study that is looking to see whether doing wide genetic testing in newborn babies could be a good way of detecting some conditions. ALD is included in that study. There are some questions around that, and we're still waiting to see how that's actually going to work out. But I think it's a question of watch this space, and there is ongoing work to see where that's going to go to. So then to come back to the topic of this talk, which is what we're doing for monitoring, and we're focusing particularly on boys with a diagnosis of ALD who haven't yet developed symptoms. A couple of years ago, Mark Engelen and a number of us here contributed to this paper, which is the international recommendations for the diagnosis and management of patients with adrenoleukodystrophy, and very much what I'm going to talk about today is aligned with the recommendations from this agreement. Again, this is too small to see, but this is a summary picture showing the different areas of adrenoleukodystrophy that we know we need to monitor, thinking about the brain, the cerebral disease, the spinal cord disease, the adrenal glands, and so on. So just a few words about the endocrine monitoring, the adrenal insufficiency. If a diagnosis has been made, whether that's through newborn screening or cascade testing, or you've had a diagnosis because you've had other symptoms, one of the first things that is done is that baseline tests to see whether there is any adrenal insufficiency. If that's all normal, you would then go on and have further testing. It says annually here, but it would depend on the age of the child, and it may be every 6 months or so that testing is done to keep an eye to see if you're at risk of developing adrenal insufficiency. And obviously, if that is found, then treatment is put in place. For the brain disease, the cerebral adrenoleukodystrophy, as we've heard from Dr. London and others over the weekend, around about 1 in 3 boys who carry the gene for ALD will go on and develop the severe brain form, the leukodystrophy associated with ALD, which can be very rapidly deteriorating with severe effects. And as we'll see and as we've heard, we know that there are those disease-modifying treatments that can stop the progression of the cerebral brain disease if it's caught early. And again, we've already heard about the 2 treatment areas, the bone marrow transplant or stem cell transplant, which is the gold standard treatment. There is also the gene therapy transplant option, which is not accessible in the UK or in Europe at the moment, but has been approved in the United States. We know that those treatments, and particularly the bone marrow transplant, it's not suitable if the brain disease has already progressed too far. And it's also not appropriate to treat the roughly 2/3 of boys who are not going to go on and get the brain disease with a transplant. There was a question yesterday, do we do that preemptively? And the answer is no, because there are lots of risks associated with the transplant itself. We don't know if doing it earlier would stop the onset of disease. So if we have a boy who's got the diagnosis, we then have to monitor them closely to spot early signs of brain disease so that we can step in with treatment. And so we have here, again, another overcomplicated slide, but you have a diagnosis that's reached. You have a scan at the beginning. If there's no brain disease, we go on and continue to monitor that. If there then becomes evidence of early brain disease, we're able to move to the green box and think about disease-modifying treatments. If you have the diagnosis and your first scan already shows some signs of brain disease, but it's early, we then can move on to thinking about disease-modifying treatment. And if you have that first brain scan and already there's advanced brain disease, then we'll be looking at what symptomatic treatment, what care is needed for, as we've heard from Alistair just now, what is needed to help with ongoing symptomatic management. But the intention and the hope is that if we are in that phase of monitoring and you don't have brain disease, that we're not going to get to a point where you've suddenly jumped to advanced brain disease and we've missed the boat. And I think our experience with the protocols we have is that we are good at picking up the brain disease in that situation. How do we monitor for it? Well, there's both the clinical aspects and looking at the history, the physical examination, using things like the neurologic function scale to make sure we're checking in and covering all those different possible aspects of the disease. And that will be done on a regular basis, and usually we'll be reviewing in clinic every 6 months or so to make sure. And obviously if new concerns come up in between, then we would bring forward those assessments. The brain scan, as we've heard, is an important part of the monitoring, looking for early brain disease, and that's important because we know that you can develop some very early changes on the scans even before it has come to light with causing any problems. And so we'll have the first scan. if the first scan is normal, we go into that cycle of repeating the scans, and the protocol would be having a scan every 6 months or so until you are 12, and after that on an annual basis. And that would also potentially now carry on beyond transition into the adult services, and that's one of the emerging areas now that we have the option for transplant for adults as well, that there would be that potential need to carry on the scans. If the scans are abnormal, there may be a repeat done within a few weeks or months, but we would be thinking about, do we step in with one of those disease-modifying treatments? I'm not going to dwell on this. We've heard about the LESS score lots over the weekend. This is the scoring system that the neuroradiologists use basically to tell us, looking at the scans, how advanced is the brain disease, from 0, where there's no disease at all seen on the scan, up to 34, which is the worst case of advanced disease. So these are some MRI scans from one boy who at the very first scan he had, you may not see it, and I'm not sure the arrow shows, but there is a tiny little blip in the back of the brain, the part of the brain called the genu of the corpus callosum, joining the two bits together. It's very small, and it's got slightly bigger on a repeat scan, and so he was able to then go in and have a transplant, and the bottom scans are taken at 1 year and 2 years and 3 years after the transplant had been done, and what we've seen is that it has stopped the further progression of the brain disease. So that's a successful outcome. What we know is if you have already got that late advanced disease, and on these scans, the middle one, you can see there's a very bright, florid, white areas where there is a lot of parts of the brain affected already. We use the gadolinium, which is a contrast dye that's injected, which lights up around the affected area and shows that there is this active inflammation and progression of the disease. So in that situation, the brain disease is already very advanced, and often, as we've seen, symptoms may not emerge until the brain disease is already quite far progressed on the scan. This is some older data, but it's reflected in more recent research as well, that we know that transplant is effective at halting the disease if we catch it early, but it's not good at stopping the disease once things are further progressed. And these data really compare the outcome after transplant. If you've had a transplant when that LESS score is lower than 9 or less compared to if it's 10 or above, and there's a huge difference at that sort of cutoff. If you've already got advanced disease, things will continue to progress even if you've had the transplant. And then my final slide before we draw a few conclusions together, just a couple of comments about the current position on Lorenzo's oil. There's a bit of discussion in here yesterday about this. Lorenzo's oil is a treatment that has been tried previously. It's a formulation of specific fatty acids, often used in association with a low-fat diet. The rationale for thinking about this is can you lower the levels of the very long-chain fatty acids, which we know are high in the blood in people with ALD. And while the evidence shows that the Lorenzo's oil can make a difference in terms of some of the numbers that you can measure, there really is insufficient evidence to see that that translates into actually making any difference with the disease. And we heard in some of the discussion yesterday that while it might change what's going on in the blood, what really needs to happen is that you change the metabolism in the brain cells themselves. And so there is insufficient evidence around this, and the national, international guidelines that we're reflecting on today has that specific statement that really there is insufficient evidence at the moment to support the use of that. Now, some children, some families have been using Lorenzo's oil, and that may still be the case, but the advice would be discuss this with your clinical team, but it's not a mainstream recommendation. And I certainly just wanted to reassure families that if you are not using Lorenzo's oil, we're not worried that you're missing out on something that you should be having. And I think also there is definitely no evidence that it's helpful if you've already got brain disease. And so I think that was just a message we wanted to make clear. So I hope that's been useful just to give an overview of what we're doing with monitoring for this particular group, for the boys with asymptomatic ALD, how we're tracking their progress, how we're putting in place really those early warning systems, trying to pick up on disease at an early point so we can step in with those timely interventions. It's important for the disease-modifying treatments. It's also, I think, really important that we're also doing that important monitoring to pick up all of those different areas that Alistair's been talking about so that we can put in place treatments and therapies to help out. So I'll stop there. I don't know if we've got time.